Yes, so let me start with global AIDS strategy targets, and all of you might remember these 395s, which mean that, and it calls all countries to meet these 395s, which means that at least 95% of HIV infected individuals should be diagnosed. At least 95% of the people who know their status, they should receive antiretroviral treatment, and at least 95% of those who have been receiving ART, they should be virally suppressed. Briefly about HIV epidemic in our country. So the estimated number of people living with HIV is around 9,500. The prevalence of HIV infection in general population is around 0.3%. You see the annual new diagnosis, new registered HIV cases annually, and you see that so this is the distribution of HIV/AIDS cases by the mode of transmission, and predominant mode is heterosexual transmission, followed by injection drug use and sex between men. And I would like to underline that we have, unfortunately, very high prevalence of HIV infection among men who have sex with men. It's around 16%. The number of registered HIV cases is more than 11,000. So main achievements since 2004, Georgia remains was the first country and remains the first country in Eastern European region which achieved and maintained universal access to antiretroviral therapy. Since 2005, Georgia has ensured universal access to the prevention of HIV from mother to child, and it should be noted that after 2007, no HIV-infected children were born from all HIV-infected mothers who received appropriate preventive treatment. And one of the biggest achievements is that Georgia was the first country in the region which introduced the principle treat all, um, which means that all HIV-infected persons should receive antiretroviral treatment regardless of their disease stage, immune status, and any complications. This is HIV timeline from 2004 until present. The support of the Global Fund to fight AIDS, tuberculosis, and malaria was crucial in the success of national HIV program. Through this support, Georgia ensured universal access, as I mentioned, to antiretroviral therapy, followed by the universal access to PMTCT and opioid substitution services. Very important achievement was that in 2011, we started provision of hepatitis C treatment to HIV, HCV co-infected persons, and it was the first instance in the region, actually, we would say, that some specific segment of population received free of charge therapy, while at this time countries did not have national programs and treatment was quite expensive. And so this created like a momentum which culminated with the launch of Georgia's hepatitis C elimination program, which is well known, and of course I will touch elimination program very briefly a little bit later. So as I mentioned, we introduced treat all strategy. We started treat all strategy in 2015. Pre-exposure prophylaxis program. Georgia was the first country in the region which started pre-exposure prophylaxis in 2017, and the program has been implemented quite successfully. And one of the main achievements was also transition to dolutegravir-based regimens. Dolutegravir is one of the medications which blocks the integration of HIV into our host cell, and dolutegravir-based regimens are now considered as the priority regimens according to WHO and other institutions, guidelines from other influential institutions. So we are providing the comprehensive HIV care package, and you see that, of course, universal access to antiretroviral therapy. In patient care, we have home-based, we're providing home-based care, diagnosis and treatment of co-infections, primarily treatment of chronic hepatitis B and chronic hepatitis C. They are integrated into HIV care. So all patients with chronic hepatitis B, they are receiving tenofovir-based regimens, and for hepatitis C, of course, they are receiving highly active direct-acting antivirals within the hepatitis C elimination program. Our patients are screened for comorbidities. You see that we are testing them on liver panel, metabolic syndrome, glucose, lipid panel, kidney functions, and also there is a very strong link. There are very strong linkages to tuberculosis services and addiction services. So, as I mentioned, dolutegravir, and Georgia introduced dolutegravir-based regimens in 2020, and you see that the proportion of HIV-infected individuals receiving this regimen, which is considered as the priority primary regimen by WHO and other guidelines, has been increasing, and by the end of 2024, about 80% of HIV-infected individuals, they are receiving dolutegravir-based regimens. Of course, other regimens are also available in the country. So this is our HIV cascade of care. As I mentioned, the estimated number of people living with HIV is around 9,500. So we diagnosed about 86%. 84% of those diagnosed, they have been receiving ART, and we almost reached this third 95%. So about 94, 95% of the persons who are on treatment, they are virally suppressed. So if we compare our cascade of care with the average numbers of cascade of care, like average in Eastern European and Central Asian countries, you see that the rates in all three rates, our rates are higher than the average in the region. As I mentioned, Georgia was the first country which started hepatitis C elimination program in 2015 with the support of US CDC and pharmaceutical company Gilead Sciences. And so Georgia with Egypt will become first countries, we hope, by 2030 to eliminate hepatitis C. And we all know about microeliminations, and microeliminations of hepatitis C is very critical. Microelimination in specific groups of populations, including, for example, patients on hemodialysis, active drug users, and of course, HIV, HCV co-infected persons. So you see that, as we mentioned, since 2011, we have been providing free of charge hepatitis C treatment to HIV, HCV co-infected patients, and we got the significant decrease in prevalence of hepatitis C, chronic active hepatitis C in this population. So about 85% reduction. So this is a remarkable progress, and we hope and we can say that we are very close to microelimination of hepatitis C in HIV, HCV co-infected patients. We are closely monitoring reinfection of hepatitis C virus as well, and latest research showed that reinfection rate is low. It's about 2.5 per 100 person years. So all these strategies and all these successes in the implementation of national AIDS responses and successful model of HIV care resulted in significant reduction in the mortality among HIV infected individuals in the country. So I would like to mention about one of our projects, and we aim to assess HCV reinfection among people living with HIV. We included about 590 persons and who were treated between 2015 and 2021, and we followed them through June 2023, and we identified 54 persons. They were reinfected with the rate of 2 cases per 100 person years, and you see that the highest incidence of HCV reinfection was seen among men who have sex with men. Um, since 2022, unfortunately, after this military conflict between Russian Federation and Ukraine, Georgia witnessed the influx of citizens from Russian Federation and Ukraine, and the country, and we can say that it is success of our program, and we tried our best to meet their requirements. I mean, requirements of HIV infected individuals who left their home countries, and you know that these countries don't have a very good profile of HIV epidemic, and our center, which is infectious diseases and AIDS center, provided HIV care to 226 persons with confirmed diagnosis. Most of them, they had confirmed diagnosis already in their countries. So we are providing all necessary lab investigations, and now the question is if everything is free of charge. So the most important antiretroviral, they are free of charge to them. So Georgia is providing free of charge medications, ARVs, to those who need treatment. So physician's consultation and antiretroviral therapy, and you see that from these 226, about 100, they are from Russian Federation, and we are providing care to 54 HIV individuals from Ukraine. Pre-exposure prophylaxis program, and Georgia was the first country which started implementation of PrEP program in the region in 2017, and the program is implemented by our center in collaboration with non-governmental organization Equality Movement, and the enrollment number of enrollees have been increasing since 2017, and here you also see that we are providing PrEP services to citizens from Ukraine and Russian Federation, and here within the PrEP program, all diagnosis and of course pills are free of charge for them. So for example, in 2023, we provided PrEP services to about 160 persons from these two countries, and last year about 85, 90 persons received PrEP services. So until 2024, we had 5 treatment centers. So 5 treatment centers have been providing HIV treatment and care services across the country. Of course, in Tbilisi, our center, and regional centers in Kutaisi, in Batumi, in Zugdidi, and in Sokhome, in the conflict zone of Abkhazia. But since 2024, we expanded the number of sites in 4 additional cities. Now the question is, Georgia is very small. These 5 treatment centers would be enough to cover their needs, but it's not a case, and so it's like a general recommendation from WHO and from other influential institutions that integration and decentralization of services are very important to improve treatment uptake. And so 4 additional treatment sites were established in 4 cities. In Tel Aviv, AKAKI, in south part of Georgia, in Akhaltsikhe, Khashuri and Poti. Of course, it was a difficult task because they did not have like physicians and specialists. They did not have experience in managing patients with HIV. And by the way, some of these sites they have primary healthcare physicians, and so we trained and we are in very close contact with their physicians. And so, firstly, we delegated only like basic consultations, checkup, and provision of antiretroviral treatment. And at present, about 25 persons are already receiving antiretroviral treatment in these four sites, and we hope that the number of persons will be increased, and finally, ultimately, of course, this decentralization and integration of HIV services in other sites will improve enrollment in care, and it will help us to move to this second 95 as soon as possible. Now, what are the main challenges of national program? The first main challenge is diagnosing of HIV infected persons, because we have only 86%, and so we are far away from this 95%. And the second biggest challenge is, unfortunately, still late diagnosis. And as you see, unfortunately, half of HIV positive individuals, they present HIV treatment providers, HIV treatment sites quite late, with CD4 count less than 350, and unfortunately 35% they have already advanced disease with many complications. So we are working very hard to somehow decrease this rate of late diagnosis, and but it's still a big issue. So what we should do, and so these are from the national strategic plan to end AIDS epidemic in Georgia. In terms of diagnosing, so we should diagnose all and as early as possible. And here we should consider strengthening HIV testing, especially in key populations among PWID and MSM population, at community organizations, to expand HIV self-testing to members of target populations, and to improve integration and to accelerate integration of HIV testing in healthcare facilities, including primary healthcare centers, at the level of community-based organizations, outreach programs, etc., to treat everyone and as soon as possible. And so we have to improve geographic access, and the process has already started. And nowadays we have 9 treatment sites, and it was a very big progress. Georgia is working and is implementing innovative models of delivery of ARV medications, and we have to strengthen mobile ARV treatment groups. We are continuing to optimize ARV treatment regimens, and the proportion of persons receiving dolutegravir-based regimens should be again increased. And we have to strengthen and integrate care mechanisms for HIV, TB, and hepatitis C, and substitution therapy for effective management of co-infected individuals. And of course, PrEP, and everyone knows that PrEP is has already become the main driver and the main weapon um, to to get closer to the end of AIDS epidemic. And it is very important to increase the promotion of PrEP, because not all clinics in the country and very small number of physicians might know what is PrEP. And of course, the knowledge and awareness about PrEP should be increased, of course, among medical personnel and in among key populations. And I should say that when we established PrEP programs, it was firstly limited to MSM, but now anyone who have high risks, including PWID, or any persons with unprotected sexual intercourse, they can be enrolled in national PrEP program, and they can receive all services free of charge. So promotion of PrEP to increase access to PrEP, not only at clinics, but at the level of non-governmental organizations and community-based organizations. And of course, we have to improve the scale and quality of harm reduction services. I cannot stop without not to mention hepatitis C elimination program, because Georgia was once again introduced on the international arena as the first model country to eliminate hepatitis C, which we launched in 2015 with the support of US CDC and commitment of Gilead Sciences to donate free of charge direct acting antiretrovirals. And our program is different from other programs, and we know that already more than 10 countries in the world, they are on track to eliminate hepatitis C, but our program builds on provision of comprehensive package, which includes nationwide HCV screening, treatment, including retreatment of all HCV infected persons, infection control strategies, active case finding, which is very important, harm reduction services, blood safety, etc. And the remarkable progress of Georgia's hepatitis C elimination program was that the repeated seroprevalence survey, which was conducted in 2021 with the support of US CDC, showed about 70% reduction in prevalence of active HCV infection. So the prevalence dropped from 5.9% to 1.8%. So it was the end of 2021. Now it's 2025, and we are sure that the prevalence would have been dropped even more, and we are very close to HCV elimination. So on the right side, you see HCV care treatment and care cascade. Georgia already treated about 90,000 hepatitis C patients with the cure rate of almost 99%. I would like to acknowledge all partners which contribution was significant in the national response to HIV. Thank you very much.
Thank you very much, Dr. ABUTIDZE. So, questions? Welcome. Yeah.
Thank you very much, AKAKI. This is a wonderful presentation and highlights an amazing public health effort. Thank you for sharing it with us. This idea of elimination of a problem as at least as a public health threat, if not total elimination, is very powerful for many diseases. But you now are on the edges of doing that. And one question that always comes up for me is, is the last mile, what are some of the challenges of the last mile? Do you have to change your strategies to reach a different population of people who have different individual characteristics or different group characteristics? Or as you open new centers and you get to different places, how has that affected the way that you deliver the basic HIV interventions?
Yes. So your question is mostly on HIV, yes? So
could also be hepatitis if you like.
Yeah, hepatitis, yes, because we have also challenges. We can go back to the slide. So in the care cascade, you might notice that about 20,000 persons who are HCV antibody positive, they did not receive RNA testing. So these about 20,000 persons. So these 20,000 persons are without treatment. And another challenge is that about 14,000 persons who are already confirmed with active chronic infection, they did not start treatment. So this is quite a big challenge, and everybody knows about this, and it's our big headache, yes, how to reach these persons, because we are talking about eliminating hepatitis C. We treated about 90,000 persons. And of course, always the end of the programs are much more difficult than the start of the program. Yes, because in 2015, 2016, 17, our hospitals were full with patients because they were waiting for this treatment. But now we have much more challenges. Yes, because our national CDC, National Center for Disease Control and Public Health, so they have been working very hard to identify the barriers why these 20,000 persons did not reach clinics, because everything is free of charge. Treatment is just only 3 months and very comfortable, but they don't want, or they don't know how to reach these treatment centers. Yes, so they tried their best to reach like the big part of these persons who were lost to follow-up, and they identified several reasons. So one part of this persons who were antibody positive and they did not reach this confirmatory testing, was that they were far away from treatment providers. Yes, so and accordingly we understand this, and we identified this as a challenge back in 2018, and we started decentralization of HCV treatment services in primary healthcare centers. So our center piloted a project, and we trained primary healthcare physicians in 10 different primary healthcare sites. This treatment site should be very close to the persons. And we would say that the decentralization and integration of HCV services in primary healthcare as well as in harm reduction centers were quite successful. We cannot say that it enormously contributed to the treatment uptake, but it showed the improved linkage to care, and also we got the same treatment success rate in primary healthcare centers. But it's not enough, of course, because we don't know exactly what are the barriers why these persons are not reaching treatment site, especially this second about 14,000 persons who already know that they have chronic hepatitis C. They were consulted by physicians, but they are postponing treatments. Yes, and so we also have close contacts with these persons, and of course clinics are convincing these persons that to avoid complications and liver fibrosis and cirrhosis, they should receive a treatment. So it's a big challenge, and the country is working very hard, we can say that, to catch these persons and to provide them treatment. And also reinfection, I forgot to mention, because when we have this program, which is hepatitis C elimination program, we have to monitor HCV reinfection as well. And our center conducted a study to assess the rate of HCV reinfection in the capital of Tbilisi. So we enrolled about 200 persons who were treated and cured within the hepatitis C elimination program. And fortunately, we got very low reinfection rate. So we are good in this. But again, these 20,000 persons who are the sources of infections, and they are not confirmed and they are not enrolled in care. Of course, they represent a big problem of hepatitis C elimination program. As for HIV, for the decentralization, so we have 5 treatment sites, and these 4 additional treatment sites were added. So currently, the number of persons who are receiving ART in these 4 new sites is very low, but we hope that the number of persons will be increased, because they have these treatment sites very close. Yes, because some of our patients, they cannot afford transportation expenses, and they cannot come to Tbilisi or Kutaisi for about 100 kilometers and more for ARV pickup and refill, and of course it's not good for their retention. Yes, and we hope that decentralization and increase of treatment sites will improve treatment uptake. But currently, of course, we have to wait. We have to wait because these 4 treatment sites which were newly opened, they were far away from specialty clinics and already existing treatment sites. And so we hope that the number of persons will be increased at receiving the HIV treatment at this center, at these centers.
Any other question? Yes. Thank you. Thank you. First of all, I was first year medical student when this program started, and I was volunteering to increase awareness about hepatitis C. And we are going door to people to explain about the program. But my question is, what actions is taken to cover rural and urban areas? We know that it's easy to cover Tbilisi and big cities, but villages is not easy to reach out. And this infection disease is problem in these regions as well. And what we are doing to just cover whole population. Thank you.
So in terms of like treatment or like including prevention services? Yeah, so of course, national CDC specialists would provide more comprehensive answers because I'm from treatment side, yes, but of course I'm involved in other directions rather than only treatment. And so as I mentioned, national CDC has the national database which captures all information about all persons who have ever been tested on hepatitis C, and they have this list of persons who are not screened. And unfortunately, there are about the day before yesterday we had the World Hepatitis Day, and we had the workshop, and of course we talked about the challenges. And unfortunately, there are still about 400,000 persons who have not been tested on hepatitis C. So it's not good for the program, yes, because we hope that almost all population should have received, of course, not all persons, but so this is one of the challenges that we have about 400,000 persons who don't know about their status. And as I mentioned, they have the list of those persons who were anti-HCV positive, as well as persons with already confirmed chronic hepatitis C who did not reach treatment. And as I know, national CDC specialists and personnel, they are calling these patients and conducting interviews and asking them why, if they know. First question is if they are aware about their positive results. By the way, some portion of these persons, they were surprised that they did not know about their status. As I know, the significant part of these persons were hospitalized persons when they were receiving hospital care for other diseases, and they were discharged, they were tested, but the test results were late received by this medical institution, and unfortunately, they were not notified about their anti-HCV positive result. Of course, in this case, it's not their fault why they did not reach treatment providers. But of course, there is a big part of persons who know their status, who are familiar with the complications, and they are not receiving treatment. So And so these persons also include persons from rural sites because this is from the national database, and so they are reached if they are available because the phone numbers are changed and many problems. And of course, some persons don't like these interviews and they refuse treatment. So multiple interventions are conducted by national CDC and by service providers because we as a leading service provider, so our center provided care to about 30% of all persons treated countrywide. So we are the leading provider, and we have also dedicated staff which is responsible to call those persons who were registered at our center as HCV antibody positive or RNA positive, and they did not continue this diagnosis, testing, and then treatment. So this is like a general answer.
Yeah, so thank you for that very, very comprehensive, conversation. I'm going to piggyback a little bit on Luke's question because you've identified the two big gaps, right? The two big gaps, at least for hepatitis C, are you've got this pool of people who have confirmed hepatitis C but not treated. And of course, understanding what gets in the way, they don't know, they don't want, they can't get, all of those sorts of things would be really important. And then the other part is the group of people who have it but don't know. So those are your sort of two gaps. And the strategies, if you, obviously when you want a different result, you've got 20,000 people, you have to do something different. I'm just wondering, as part of your next generation of plans, because it's been sort of stepwise, have you thought about, sort of strategies where you use a PCR test and treat on demand? Because for example, in many places around the world, we don't have physicians involved in it at all. It's an outreach worker who asks a couple of questions. So is that maybe perhaps one of the plans for the people who aren't getting treated, who can't get to the centers or who don't? So that's a potential idea because that's a pool of people who who they are. And then I'm just wondering that if there are some restrictions and you can't get to that quickly, are there ways to, let's say, do outreach linked to, telemedicine or a telephone call or something like that? Because these patients really don't need complex workups. They don't need us physicians, but about that much. And I'm just wondering, how do you think about what the next strategy is going to be? Because you've got this really effective treatment, 99%. It's incredible, right?
Yes, Professor. So we have been thinking about this for several years. So we have national workshop and technical advisory group meetings almost every year. And of course, these suggestions are articulated and mentioned very rigorously on this at these meetings. And of course, I fully agree that these strategies are timely, and this is real time to switch to new strategies. Personally, I am an advocate and I support first aid treatment. So if a person is RNA positive, so they should receive pills because they are already enrolled in care. Because I'm involved in this program from the first minutes of this program until nowadays, and about 50% of my workload is dedicated to hepatitis C elimination program, and we are into much details and we are very close to the patients. And some patients we are losing when even if they are coming to our center as a leading provider and they are confirmed with hepatitis C, with RNA, and some time is needed to collect their liver function panel, ultrasound, and it takes about 10 days or 2 weeks. And even these 2 weeks and 10 days make some people to refuse treatment and to postpone. Yes. And of course, the government of Georgia. So we have been discussing these strategies to the Ministry of Health, and of course, the Ministry of Health should change, and we hope that, and we think that this is the real time, because we are at the end of the program, which is much more difficult when we were in the middle of the program, and at the first days of the program. So first day treatment, and because as you mentioned, we have 99% cure rate with pangenotypic regimen, and of course telemedicine. So we are providing telemedicine services to some patients who need, but this this telemedicine has not replaced in-person contact, which is outlined in the national protocol. In this case, we have to modify our national protocol, and I fully agree that most of these persons, especially who are not cirrhotics and who don't have any liver fibrosis and complications, they can be managed through telemedicine, and it will improve treatment uptake and treatment completion rates.
Thank you very much.
Yeah.
Last question.